welcome everyone, and thank you for joining us for today's webinar on streamlining induction. Keen to unpack this topic. Before we do begin though, I would like to acknowledge the Wurundjeri people as the traditional owners of the land of which I am presenting on today, and of course pay my respects to the elders past, present and emerging, and acknowledge the impact that they continue to have on our learning practices. It is nice to see so many familiar faces. For those of you who I haven't met before, my name's Zoe. As you can see, my passion is cooking. I did a lot of cooking over the weekend. We hosted a big barbecue, lots of charcuterie, slow cooked lamb, some of my favorites. I know it's lunchtime, so I won't share too much more about my cooking, but love cooking. Je parle français. A few of the team didn't know I actually speak French, and when they were checking my slides, they found out that fun fact about me. And professionally, I would say passionate, maybe even borderline obsessed about the evaluation and measuring the return on impact of education. A little bit more formally though, I'm a critical care registered nurse. So I specialised in intensive care, but worked in oncology, hematology, palliative care, neuro, all sorts of wonderful wards before joining AusMed. So I've been here over 10 years now and worked internationally setting the scope and standards of practice for predominantly nurses who work in this area. So there's a specialty called Nursing Professional Development. I'm an active member of this community and also director of our accredited provider unit. So within AusMed, we have an accreditation unit, and our courses are accredited with distinction. So through those roles, I guess I've been able to build on my clinical and education experience, and over the years at AusMed gained exposure to clinical governance, risk regulation and compliance. So excited to sort of tie a few of those areas of interest and expertise together today to look at streamlining induction. So what we'll aim to cover in the next 60 minutes, and I want to be mindful of your time. As we all know, time is a big cost, a big challenge. So I want to respect your time, make sure we finish on time. But we're going to look at these 4 areas. We're going to review our understanding of the role of induction training. Sadly, there are a range of challenges that we all experience when it comes to induction training. So we'll look at those and then move into best practices for streamlining induction training, and then look at evaluating and then optimizing some of our induction training and induction programs. Alrighty though, let's start with the beginning. What's induction? Well, we know it's a formal process of introducing a new employee to an organisation and providing them with that really critical information about workplace culture, policies and expectations. According to not Fair Work Australia, we'll get to Fair Work Australia shortly. According to Safe Work Australia, induction training is compulsory part of this overall induction process. And it's designed to equip, sorry, I'm in an office and the incredibly loud motorbike just went past. The purpose of induction training is to really equip the new employees with those essential skills to perform their roles safely and effectively. So we want them to feel welcome, we want them to feel prepared and ready to contribute, but I really want to emphasize those words, safely and effectively. Let's hold on to them. So we know induction training is absolutely needed within the healthcare setting. It's critical. It provides that structured introduction, particularly to our workplace safety standards. And it also introduces the new starter to more of the clinical expectations and, of course, the organisational policies and procedures. So we're really trying to help that new starter understand the context of which they're coming into. And when it's done well, we know that there are many benefits that we can reap the rewards of to induction training. There are the benefits to ensure that safety and regulatory standards are met. And research from the Australian Government Department of Employment and Workforce Relations highlights that up to 20% of employee turnover occurs within that first 45 days. So there really is a productivity gain and reduced recruitment costs if we can retain that talent. So if we can prevent some of the complications and concerns that we see around induction training and do it well, there are a number of benefits that us as organisations, employers and teams can benefit from. So there are several terms which I guess are used across the industry, in hospitals, in aged care, in the community, some of which are used interchangeably. I'm going to define them for clarity, but don't get too caught up in the terminology. Some of the concepts overlap, but when I was researching this topic, you hear onboarding, induction, orientation, and I just want to try and set the scene by thinking, how do we differentiate between them? So let's start with onboarding. Think of onboarding as the entire process of integrating an employee into the workplace. That begins at job offer and it typically ends at probation or the end of probation, which is usually around that 6-month mark. Induction training, as we've covered already, is mandatory, and that is part of that overall onboarding process that aims to ensure our new starters gain those essential knowledge and skills required to perform their role, remember, safely and effectively. We've then got orientation, and that is really a core component, and it can last up to the 12 months. Best practice and, organisations that are really doing this well see actually the first 12 months as being the most vulnerable. So an orientation program of different shapes and sizes can often last for that 12-month period. And we differentiate orientation as more specific to the actual job role and requirements. So less about compliance, less about the workplace, and more on what's going to help that new starter in their specific role. And then we've got a concept which I know will be familiar to many of you that work in hospitals and in acute care setting. As I mentioned, I'm a registered nurse and I went through a transition to practice program. So I want to introduce this concept within the discussion of induction to help think of that bigger picture, because where we really want to go is from, meeting those basic compliance requirements and shifting towards building competence, building confidence, building our workforce capability. And our transition to practice phase really assists to move that new starter, to move that clinician to that place. There's often a lot of time and resources within an organisation that go into creating this type of program that's really underpinned by mentorship and support. And of course, it's not limited to just new starters. We can have a transition practice to an employee that's moved from one ward to another, that is stepping up into a management role. There are a number of situations that may warrant someone to be a part of a transition to practice program. So here's some of the goals and objectives of each of those different parts of the process. They vary slightly, and there are some important differences which I think are good to note. And I guess starting with induction, the objective, which I will keep banging on about, but we're in an induction webinar, but we're looking at core safety, core compliance, understanding clinical expectations and workplace protocols. So that's really the objective of induction training. Whereas the objective, as I said, of that more 6-month longer onboarding program is to enable new starters to really contribute effectively by that end of the probation period. And anyone who's in an HR role will know exactly when that probation period ends. We know that's a really critical milestone to be aware of and to really support someone to get to that effective place, but to know when that period is, and if a change needs to be made, we of course need to know when our probation period ends. Moving on to orientation, as I mentioned, because it's that longer up to 12-month period, the objective really is to start to support them to build that confidence in the role. And as I mentioned, when it comes to transition to practice, we're really trying to bridge that theory to practice gap. So the typical example, as I mentioned, you've got a graduate nurse, prime example of when that type of program is really important. We need to move them from being, within the theory, the theoretical approach into real world situations. All right, so I want to, we're getting closer to what does induction training need to cover for the different organisations that you all represent. We need to start with obviously the regulatory requirements. So there are workplace laws that apply to all employees. And before hiring, many of you will already know this, of course, that we need to make sure we understand our responsibilities under the Fair Work Act. These include our national employment standards, various awards and agreements, wages, discrimination, record keeping, pay, tax, super, and workplace health and safety, which includes our workers' comp programs. So as an employee, there are really critical to emphasize that we're responsible for providing a healthy and safe environment. In addition to the Fair Work Act, there are several other acts relevant standards that apply to induction training. Now, obviously, each state and territory has a local workplace health and safety body. You've got Safe Work New South Wales, WorkSafe Queensland, I think it's WorkSafe Victoria. These are the regulatory bodies that investigate any breaches of laws around workplace health and safety, and they're your best source to clarify any uncertainties that you may have. In terms of our national standards, we've of course represented the key quality standards that sit across our aged care, community home care, acute care, and disability care that you see on your screen. So big picture is that we have legislation that mandates the need for adequate training, and our national standards really do, particularly in the strengthened standards. It's really pleasing to see that they outline the importance of training and supervision, but do they actually specify what specific topics you should include in an induction program? What should we focus on? No. We will get closer and closer to identifying that. Hello there. But if we think of the strengthened standards, there are a few key elements to draw your attention to. Within Outcome 2.9, Human Resource Management, we've got Action 2.94A, which really clearly states that a provider must maintain and implement a training system that includes training strategies to ensure that workers have the necessary skills, qualifications, and competencies to effectively perform their role. So very, very clear. In the NSQHS standards, so that the Australian Commission on Safety and Quality in Healthcare set, Action 1.19 states that a health service organisation must provide orientation on safety and quality roles and responsibilities, and that applies to all staff. So from our board and our governing bodies, clinicians, even contractors, locums, students, and volunteers are represented in the NSQH standards as staff or students who need to have that basic safety and quality training provided. So a little bit more specific than the strengthened aged care standards. And NDIS practice standards probably a little bit more broad. In some sense, they identify that within good provider governance, that a system must be in place to identify, plan, facilitate, record, and evaluate worker training. So pretty general. There are much more specific references than within the practice standards about where training is needed. But we don't have that $1 million question, do we? What training modules should we include in an induction plan? How long should it be? I can't in my travels find this list. So I'm sorry if you've come to the webinar looking for the source of truth on what should go in it. I don't think it's out there, but we can, explore what exactly that induction training should focus on. So we're getting closer, I can assure you. Now, really 3 key things. So induction training should primarily focus on ensuring new starters are equipped to implement core compliance, highly specific organisational-based training, and also receive more clinically focused or role-specific training. So there are three core areas that induction training should primarily focus on: core industry compliance training, organisation-specific training, and more clinical focused or role specific training. You'll get these slides sent to you tomorrow when we send the recording. So take notes, screenshot if you like, but you will get these tomorrow. So from those specific areas, we can break core compliance, so our first aspect, into 5 priority areas that training should focus on. So that core compliance training includes workplace health and safety topics, incident reporting. You're going to come back to safety. I know you may not think that topic, we've got a module of that title, may not be in the plan, but when you think bigger picture of what exactly incident reporting achieves, and that's a safety outcome. Clinical safety topics, emergency procedures, and of course our legislative compliance. So within the core compliance training, there are the big topics that we want to be seeing. And then, of course, we've got the next section being organisation specific training and our role focused or clinical focused training. So we'll keep unpacking, what exactly these requirements are. Okay, so bear with me. I know it's a big slide in front of you, but I think it's really important that we sort of get those critical thinking juices going. What I like to think of is the outcome. If we think of best practice, we're trying to think of what's the outcome? What's the desired outcome of induction training? Yes, it's a tick. We want to know that it's done, it's been completed, but really, what do we want the new starter to know, be able to do? How do we want them to practice? And if we can think of it from an outcome base, then we can really start to think what's a need to have, what's imperative versus what might be a more nice to have topic that we include in an induction program. So I'll just read a tiny bit here, but workplace health and safety, what do we want new starters to do? Understand and apply those policies to help contribute and be a part of a safe work environment. I mentioned incident reporting before. Why would this be an important topic within an induction program? It's because we need any new starter from the minute they walk into our organisation to be able to report on any safety issues accurately and understand their role and responsibility within that process. In the settings that we work in within healthcare, within aged care, there are many, many clinical safety risks and hazards. We want our basic induction training to help identify and begin to start to minimize some of these clinical risks to themselves, but also their clients and patients. You think manual handling, hand hygiene, basic sharps management. They're critical things that we want, a degree of high assurance that is covered as soon as possible. Of course, emergency procedures. Again, thinking of their outcome, that they can follow our organisation's procedures. If at lunchtime on day 1 of an orientation, there is a fire, that we can, be assured that they will take the correct steps within our protocol. And it's a little bit harder to kind of create a learning outcome around, but thinking of those legislative matters, at least come out of induction training and demonstrate an understanding of some of those core relevant legislation and standards and be able to apply them in their day-to-day practice and responsibilities. If I think of the strengthened aged care standards, dignity, respect, privacy, within a general module on, let's say, the strengthened aged care quality standards, we would hope that the new starter picks up some of those core aspects and can begin to apply them in the role. Of course, we have a large library of modules at AusMed, and what you're seeing here are the core industry compliance and role-specific requirements. So if I start from top left and move along, this is what we commonly see as the core industry compliance module. So you've got workplace health and safety, bullying and harassment, manual handling, cybersecurity being a big one that organisations have added over the last few years. Fire safety, I've listed aged care there but obviously we've got a home care version as well, different protocols when it comes to fire in the home. Open disclosure and apology, incident reporting, hand hygiene, and basic life support. That rounds out our core industry compliance modules, with something like fire safety being one that we might be a little bit more sector specific and tailored to where we work. The bottom row contains our role specific requirements. So this is where I'd really, without just chucking something in a plan, I'd really be thinking, can I differentiate between, let's say, a care worker, someone working in a food handling role, and then a registered and enrolled nurse? So we typically see the infection prevention and control module as a second infection control, adding on from the hand hygiene module, assigned to registered and enrolled nurses. And then, of course, you've got your food safety that's just relevant to food safety roles, and something like a choking management. It ticks the box of really providing almost that general first aid, but really specific to, say, a care worker's role. We want them to be able to act safely with a degree of assurance that they'll follow our policies, of course, if that situation arises within, them just joining. So, as I said, what you're seeing here are the core industry compliance and role-specific requirements that we typically see. Moving on to that third priority area are those legislative matters, and this is where it really does need to be sector specific. So we're looking at what are the, within aged care, we've got something on the standards, we've got our code of conduct and charter of aged care rights, SIRS, and minimising restrictive practice. That's aged care specific. So when we get to legislative matters, always ensure that they're specific to the sector that you work in. For acute care, obviously, we've got more of the NSQHS standards and a minimising restrictive practices in healthcare settings. And then you've got the 2 NDIS modules. So not rocket science, but important to note that, when it comes to legislative matters, make sure that they're relevant to the sector that you're working in. All right, so I'm moving quite quickly, but what we've covered are those core industry compliance requirements. Moving on to the second, and that's organisational specific training. So you're really the experts on what your organisation deems to be important, and whether or not it's included in an induction plan. The format and duration of that activity will obviously vary. So some of these may be delivered face-to-face or online during, say a supernumerary or orientation day. But, what we need to think about within this aspect is, what are the organisation policies and procedures that we really want someone to know from the get-go? There are numerous policies and procedures within any organisation, let alone healthcare. What are the essential ones that we need staff to acknowledge from the get-go? What are the core technology systems, reporting tools that you need? And that will vary. If you're an L&D coordinator starting in a new role, you want to have induction training on the learning management system. If you're in a clinical role, understanding your EMR or your electronic medical record is going to be critical. And of course, we see other items included in this aspect: pathways, communication, and of course those team roles and responsibilities. What I will say is keep this list manageable, all right? We will look at some strategies very soon that organisations are implementing to assist with managing training fatigue and educator and facilitator workloads. It's a huge, huge issue. We're going to come back to these strategies, but I think and I will introduce a concept shortly, but there's a bias to add and a reluctance to remove items from training plans, particularly when we see the word mandatory or compliance. So keep that list manageable for your organisational specific requirements if you can, because that's going to help reduce some of that training load down the track. All right, moving on to clinical focus or more role-specific induction training. It really, focuses on the key responsibilities and skills for the different roles within your organisation. And spacing these out is critical. And I've got a graphic to show the importance of that in a moment. But we want to get that compliance training done, be confident that we've delivered our core matters for the organisation, and then start to introduce some of the more clinical focused and role specific items. So what you're seeing here, common examples of that more clinical focused induction topics that we see with a care worker. You've got items like responding to deterioration. Again, remember, we've got safety. Safety is a core aspect of induction training. Would assigning a module on recognising deterioration improve safety? Absolutely. That's going to enable that new starter to hopefully pick up on those subtle cues that a person is deteriorating. Medication, prompting and assistance. Yes, it ticks the safety box, as well as being, highly relevant to the role. And then moving through quite quickly, skin integrity, pressure injuries, falls, dysphagia. These are all tied to really important quality indicators and areas of clinical risk. They are high impact, high prevalent, meaning if we have a pressure injury, there's a potential for that to be serious, to escalate, to cause harm, and to be costly. So there are some, there's real rationales for these, modules being shown in front of you. Dysphagia. We have a choking incident, or someone isn't safe to swallow and receives the wrong type of food or liquid. It's a safety issue. And then we also, very commonly see items around dementia, supporting ADLs, palliative care, and then a general health and wellbeing amongst the care workers. For registered and enrolled nurses, again, think of the scope of practice, particularly in an acute care setting. You might have CVAD, central venous access devices. You might be, the nurse is highly likely to need to draw blood, so something on phlebotomy. These are all, safety and really highly relevant to the role. They're just some examples though, and again, we've got a little bit more of that administrative role. There's less to cover here, but really thinking about, what are the items that if we can get someone engaged with this learning early on, how might that help our organisation, our teams down the track? Thank you. We're done, right? I've given you the list, given you a list of items. What should be in your induction plan? We can call it a day. Not quite. If only if it was that easy, hey? But we know that there are some significant challenges of induction training, and we're going to move on to exploring these. So in this section, what I really want to try and pick apart is some of the challenges, look at the impact of them. I'm going to share some benchmarking data with you. And I want to introduce this concept of compliance bias, and maybe start to think about why we're having these potentially overinflated induction plans, and then we'll move into our sections on some solutions and optimizing things. So, alrighty, I don't think any of these on your screen are going to be new to you. We know that induction training can present several challenges that impact our new starters and our organisations, and particularly for those of you here that work in education, L&D, human resource teams. These are the 8 prevalent themes that we've identified across sectors, across job roles, and I thank you for all your responses that you provided when registering for this webinar. So let's go through them. Time constraints. I'm going to list them first, and then we'll unpack them a little bit more. Content overload. If any of these are new and you haven't experienced them, pop your hand up. I will monitor our hands, and I will be surprised. But I'm keen to, Vivi, you don't have content overload as a constraint, or you're putting your hand up because you do see this? I reckon you're putting your hand up because you see it. Is this a challenge you face?
Yes, it is.
Yeah, absolutely. So I don't think any of these are new. Time constraints, content overload, compliance requirements, engagement, coordination and logistics, relevancy, and consistency. And let's not forget supporting socialization. It's not just about compliance. There's a big integration and socialization piece. All right, so I think that's screenshot that. Challenges of induction training. This is what we're up against, right? This is what we're trying to improve. All right, so starting with time constraints, clearly there's limited time. There is limited time available for our new starters and the organisation, including yourselves, to actually complete that induction training. And we have challenges around duration and the frequency of which we're having to induct new staff. So there's a real ongoing demand for teams to train. Content overload, content information overload. Do we think anything is absorbed, let alone retained, if we're delivering too much information too quickly? No. So we can't fit everything in. We don't have the time. And then we're finding it really difficult to retain information. And it's overwhelming. Even reviewing all of the relevant laws, legislation, acts when I prepared this webinar, it is really hard to know how to meet these regulatory requirements, let alone if you've got a misalignment between what an executive team want or need, an OH&S team want or need, an HR team, an education team. It is challenging to have everyone's needs met, and we can have a lack of certainty, and it can be really overwhelming. Our next challenge is probably more describing the new starters experience, but not always. I've yet to meet, a nurse educator or facilitator that absolutely loves running induction training. But for our new starters, we can see, pretty low engagement. We can, see that affect their commitment to the new organisation. And there's certainly a correlation between the quantity, the quality and method of delivery of training and those engagement levels. There's more. So there's 8 themes. We're up to 4. It's a lot to sort of deal with to begin with, isn't it? But coordination. Who has to manage schedules? You got a resource over here. You're trying to minimize the disruption to the ward or the area, but you need it to be consistent. You've got one site here, one site there. There's a lot of logistical challenges around managing schedules, let alone those important resources, your educators, your facilitators. Big challenge there. Relevancy, with all that in mind, what do we need to cover, but how do we make it align with that role, with their new role? And then there's a challenge of making sure it's up to date. So, we have an entire education team at AusMed. Half of that team is responsible for making sure our modules are up to date, and that's a full-time role in itself. Within resource constrained teams, that's a big job if you've got your own material that you're constantly, needing to make sure is relevant and reviewed. And consistency, we want some individualized approaches within induction training when it comes to being, role specific, but really we need to make it standardized. We need to avoid that variation. So, really trying to tailor the relevancy to the role, but then ensure new starters receive that same quality, that quantity and level of training, and that your departments, your locations, people doing different shifts get access to that is another challenge. So, variation in practice, especially in an acute care environment, is highly costly. It causes harm to our patients, to our residents, our clients, and it can cost. So we really want to try and avoid that variation, which is, where part of the need for standardized induction training and mandatory training comes in. And then finally, we've all been there, right? We've all been in a new role, and you might tick the box, you've done the training, you know where the toilets are, you've got your pay slip, but integrating into that new culture, building relationships, feeling that sense of belonging, that takes time. And, it's a really critical step. But as leaders, we need to invest our time, our resources. We need to buy into that process, and we need to have others in our team also buying into that. That's a really critical aspect, the support of that socialization, integration into the workplace. All right, so these are all familiar, right? We know it, we live it. I'm sure you acutely experience these challenges, and critically, there's impacts of these to not just to us and our teams, our organisation, but to the new starter as well. So lack of time, the impact on new staff, they're going to feel rushed. They're not going to retain any knowledge, and we're going to likely see skill gaps that arise. From an organisation's perspective, that lack of time is more related to, or the constraint of time, it's costly. Time is money. But we also might see incomplete training because it's been rushed through. And then a flow-on effect being a reduced productivity because, that new starter hasn't actually absorbed the information that we want. And maybe even, reduced productivity of some of our core expertise in our teams. Your clinical facilitator yet again diverted from a core duty on the floor to deliver induction training. That's going to cost an organisation. Overload, I mentioned it. Poor absorption, poor retention. Is anyone familiar with Ebbinghouse's forgetting curve? Pop your hand up if you have. If you're not familiar with it, Hayley, lovely to see you, Hayley. Come on, jump off mute. Tell us, Jackie. Does someone want to share what Ebbinghouse's forgetting curve is?
Yeah, I think it's where if you don't use it straight away, that knowledge drops off. And I know this because I just reviewed your beautiful presentation on CPD and its value. And you mentioned it there.
Yeah. Extra points for you, Jackie. Well done. Absolutely. Like literally, if you don't use it, you lose it. But there is knowledge decay that literally happens within, I think it's like 12 hours of training. So I'll just let someone in. Hello, Ganda. Welcome. Got to call out the latecomers.
I was here, but
I'm only joking. I just see your name popped up, so I couldn't help myself.
Sorry, I'm so sorry. When Ravi calls you from HR, you need to answer.
Yeah, that's it. Answer to HR all the time. Absolutely.
I apologize.
No worries. So, if we're not absorbing it, we're not retaining it, we're already up against, known impacts to knowledge retention. And it's one thing to retain knowledge, but remember, we want to translate that into practice. We don't just want to remember it, we want to apply it. So not having that adequate learning environment and absorption of knowledge, like good luck trying to apply that knowledge, in 6 months' time. Impact on organisation when it comes to overload. We're really, unfortunately, seeing a concept I think you'd be familiar with, like a false start or new hire attrition. So we've had that sunk cost go into the hiring process. We've got them, we're doing induction training, but they're not going on to complete that. So, there's a huge cost to an organisation when that occurs. But overload, packing too much into the mandatory compliance stuff is only going to delay that, is only going to delay that progress to getting that person ready for their first shift. And we've got a higher risk, higher likelihood of errors if the new starter hasn't actually absorbed and retained any of that information. When it comes to compliance, I think a concern that is absolutely valid that we see and I know is common is that rushing through training and that potential gaming of the system. Click, 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 click. This can certainly disrupt or impact our compliance. We don't have any assurance that it's been absorbed, and it might show up in an operational or clinical sense when you've got someone on the floor. You've seen a record that they've completed it, but have they actually done the module? Potentially not. Engagement, I think, this is pretty obvious and something you'd all be familiar with, but poor focus, lack of motivation, maybe lower morale from the start. We've got lower ramp up time, so more costly, productivity lost. There's that attrition again, that false start. And we're paying for training, but the engagement with it is low. So there's another page. There's a lot that we're all up against when it comes to induction. So we'll keep unpacking it, and we are going to get to solutions, don't worry. But I think coordination, really manifests in probably the educator or facilitator roles. It may be frustrating for new staff, but not being able to get your dedicated time off the floor that you want to use for that staff training is a real challenge. We're balancing the need to have adequate numbers on the floor, but then the importance of training time. I know it's a tricky one, and it can feel a bit like we're the meat in the sandwich sometime there. Relevancy, I think it touched on it a little bit, but if someone can't actually apply what they've learned, one, as Jackie said, they're not going to remember it. If they're not using it, they're losing it. But it's really a cost of wasted training time. If we're paying staff to complete this induction training and it's not actually relevant to their role, it's just money down the drain. Consistency, I think, a big impact of this is variations in performance, and within healthcare that can really be costly. And finally, the challenge of socialization, I really can't overemphasize it enough, that it takes time to acclimatize to that new role. We've all felt those feelings of isolation, disconnect, lower confidence, but we really want to build that connection to the workplace culture. Culture is gold. Culture is everything. It's the glue that holds everything together. So if we don't get induction training right, we're really going to impact on this retention rate of the new starter. It's going to impact on their connection to culture, their engagement and motivation levels. So, that's on us. I think most of us here, when I see your names and where you work, we're in positions where we can be leaders and advocate for best practices. And it does matter. It really does matter. Just put yourself in that new starter's role, in that new starter's shoes, and remember when you're new to a role. I remember I was I think it was the first day of my orientation as a grad year, as a graduate nurse, sorry. I worked at a big hospital in Melbourne. Second session, the CEO of the hospital walked in, and he shook everyone's hand. It wasn't just graduate nurses that were orientating that day. It was everyone. And I loved that. I loved being, we had our grad nurse sort of more specific training, but he shook my hand and he said, "Hi, Zoe, I'm Martin. Nice to meet you." And I was, baby nurse at the time, just blown away. Oh my goodness, the CEO knows my name. Or said my name, and shook me in the eyes and wanted to say hello. I thought, I thought that was a really powerful thing, and we'll get to it shortly. But there are some low cost, if not, if anything, no cost solutions that I think, really relate to that socialization piece that we can get creative with. All right, so we're going to change this, right? I know we've covered a lot of challenges, a lot of impacts of it, and I know there's noddings. There's like, yep, that's me, that's us, that's what we do. So we're going to get to the solutions very, very soon. But I did want to just touch on benchmarking. I've got some stats, some data to share with you on the next slide. Does anyone do benchmarking? You can see on your screen what it is. Pop your hands up and come off mute and just share a little bit about what you do if you do it. But it's essentially, it's collaborative. It's based on it's voluntary. It's a pursuit of performance, and it's really seeking out not just best practice, but best cost. And so I think when it comes to induction training, benchmarking is critical, because we're trying to deliver the best possible result, but cost really matters, right? So haven't seen any hands. That's okay. You're all going to do some benchmarking now. All right. What you're seeing on your screen right now is the average number of resources in a training plan across our different sectors. And you're also seeing the approximate number of minutes of each resource. And I've got some more global data to show you in a minute. So at the top, you've got disability care, the lowest number of average items in a training plan, 11 in an acute care plan, 16 in home care, aged care, 21 resources. What does that look like? Over 8 hours of induction time training is the average training plan length for aged care. That's big. We've got 7 for home and community care, 5 for acute care, and 3 hours for disability care. So what are you seeing? Does anyone want to come off mute? Do you want to share something, anything that's jumping out? Any thoughts, feelings, reactions? Hi, Nikki, how are you?
Good, thank you. I would say working in a perioperative area in a tertiary institution, I could blitz that 8 hours with what's expected of our induction process, which is it's too much, Zoe. It's too much.
Absolutely.
And really difficult in my area to reduce it down.
Yeah. Yeah, I agree. I think, what we're not seeing there is, a critical care environment as a separate sector or setting. Yeah, I agree. Yeah. I can understand that. Does anyone else have any thoughts or any comments they want to make? Hi, Cyan, how are you?
Hi, can you hear me?
Speak a little bit louder or come closer to you. Yeah, that's better. Yeah.
Can I ask, sorry, it's a bit loud where I'm sitting, would an orientation be included in this, or this is purely online?
Great question. Yeah, purely online. I've got a great visual to share with you in a minute. You're spot on. Online training modules, excluding any face-to-face orientation that you might be providing. Yeah, beautiful.
Sorry, 2 for 1. Maybe I'll ask everybody, are we paying for the online induction, or is it unpaid?
Correct. Yeah, no, this should be paid. There'll be many more HR specialists in the meeting than me, but this should be paid per the FAY work, fair work, unpaid work. Yeah. I see some other hands up. I'm going to encourage you pop your comments, reflections in the chat. I'm going to keep moving because we still have a bit to cover, and I've just looked at the time. Why is this? Why are training plans too long? I've got a great article, stay tuned for it, that I'll publish in the next couple of days, but I just want to introduce concept of compliance bias. And I think what we're seeing within healthcare, particularly aged care, is we've had a huge period of regulatory change. There's high emphasis on compliance. That is critical, but it's good to be risk adverse. I think it can, being a risk averse means, we can drive safely. But in this context, I think some of that mentality, that bias for compliance, that reluctance to let something go, is maybe why we're seeing such sort of inflated training plans, which is having a big impact. So we're here to help. I know many of you, recognise you and you with us at AusMed. So reach out, or if you're not, still reach out. If you want to take some time to look at your training plans and think they may be excessive, then let us know. So let's fix things, right? 3 strategies. There they are. All right. Mindset, staggered training, and recognition of prior learning. I'm going to go through each one, but I'll leave it on the screen just as we are a bit time pressed, so that you can read as we go as well. So starting with mindset, I think it's really critical that we embrace induction training. It is so important. It is necessary. It's a legal requirement that we provide it, but it's only one piece of that bigger transition to practice program. So just think, what do I really critically need someone to know or be able to do as a result of induction training, and be reassured that hopefully you've got a broader orientation or transition to practice strategy. You've got other ways to upskill, to cross-skill, to improve that competence and build that workforce capability, particularly in your clinical role. So mindset's critical. Induction is important, but it's just one piece of the puzzle. Let's not get too caught up in it. So I think with that mindset, we can really try and reduce the over-reliance on induction, avoid some of that bias, and have other solutions in place to help integrate a new starter into their role. When it comes to staggered training, this is streamlining at its best. It prioritises regulatory essentials, and then moves into organisational based requirements, and then role specific training, and it aligns closely with other transition to practice programs. So there's also a need, I think, within this staggered training to get a bit creative with some of those no cost or low cost socialisation strategies. And then we've got recognition of prior learning. So I know a few of you use the AusMed Passport. It's a way to allow organisations to avoid that redundant training. So if someone has completed a SIRS module, a hand hygiene module, and the organisation is using AusMed's Passport, it removes the need for that repetitive training, speeding up that onboarding process and reducing costs. So I'll share a little bit more about that in a moment. Moved a bit quickly. With the staggered training and RPL, we really can combat those challenges of the lengthy, disengaging induction programs, reduce cost and save time. All right, so staggered induction training is spreading out the delivery of training. So rather than cramming all of the content within the first days, we're spreading it out. Again, there's a visual coming up to help you look at it, but it is going to minimize the risk of disengagement, training fatigue, that false start or new hire attrition, and really be more effective. We're looking at a best practice here to transition to practice, and it can really help you manage that facilitator or educator load. All right, so visually what you're seeing is what I've tried to recreate, what we're seeing some organisations do really, really well at the moment. The big picture is that we're trying to achieve a safe and efficient transition to practice, and we're trying to get socialisation to the workplace happening. Onboarding is that entire process of integrating a new starter. I mean, if you think back to those early slides, it's typically that 6-month period. Induction, training and orientation are some of those core components of that overall onboarding piece. Now, see that red line at the bottom? That is our highest risk of attrition. Between 30 to 45 days is what the data says is our most vulnerable period for new hire attrition or false start, and it can be incredibly frustrating. So what we're seeing is a couple of things. So if you work in HR, it might be more familiar to you already, but we're seeing something called pre-boarding. Now that's the period between someone accepting a job offer and their first day. So using pre-boarding, and I'll share some strategies that are suggested to maximize that period, can be thought of as a subsection of that overarching onboarding process. If we drill down now onto staggered induction training, this is what we're seeing some organisations do really, really well. In that pre-boarding, so think of it almost like day zero, after a contract is signed and that sort of, basic HR, police check, working with children check, whatever stuff is verified, organisations here are validating prior learning through tools like the AusMed Passport. Or they may be requesting the new hire to complete some of their organisational specific items before day one. So I've checked with an HR specialist who has confirmed it would be reasonable for an organisation to request an employee to participate in some pre-boarding activities like reading material, anything that can help them become familiar with the organisation and their role is deemed appropriate here. Within then that 7 days, sorry, I've taken the timeline away from the bottom, but so you've got before day 0 as that recognition of prior learning, then and that core compliance stuff. Within that first week, I will actually go back for the second slide here. What we then are seeing is organisations spread out the organisational specific induction and any extra compliance modules within the first week, and only moving into role-specific or more clinically focused induction training that's individualised to the role after week 1. So we need them to complete it, but at least we're minimising that false start, and we do see it. We do see, someone doesn't even make it through to the end of week 1. So at least moving it a little bit further is assisting. And then you've got, the other activities like your orientation to come. Just quickly on AusMed Passport, what it is, it's one of our genius ideas from our innovative, tech team that created a free digital certificate that fast tracks induction by recognising prior learning and standardising 8 core mandatory training areas. So at the moment, it's currently available only as an aged care training passport. If you're outside of aged care and want to explore it for your organisation, definitely reach out. We'd love to chat. How it works essentially is that a staff member can carry it with them. We see so much duplication of training and so much staff turnover and movement that for that particular staff member, they're at least demonstrating that they've recently done a particular module that AusMed offers for free and can have that recognised by the next organisation that they work with. So it's really aiming to address this saving time and reducing costs while still ensuring compliance. So super simple. Someone does the learning, it's free, they share it either on LinkedIn. Honestly, I look at LinkedIn, there's so many people that share that they've done the AusMed Passport or on the CV, and then an HR specialist, HR team can really quite quickly verify that training has been completed within the time period. So in general, recognition of prior learning, whether it's via something like the AusMed Passport or not, it's really trying to acknowledge what new starters have already completed and preventing the need to pay for repetitive training to then speed up the onboarding process and ideally free up that time to focus on other training needs that are maybe a little bit more pressing. And of course, many of our modules that I shared earlier are already in the passport. And if you're interested, as I said, reach out. We'd love to hear from you, whether you want just more information. I'm not sure how it could work for your organisation. Michelle, our Chief Customer Officer, coordinates this, and I know she'd be more than happy. It's all free. There's no cost. Anyone can use it. So if you're interested, scan the QR code, and I know she'd love to chat. So, all right, last little part. As I mentioned in my introduction, my passion is evaluation, and I just want to plant the seed. How are you evaluating your induction program? And again, encourage anyone, I know we're just about at time, but if you want to jump in and share just really quickly how you're evaluating it. Have we got any head of people and culture, any HR managers on the call that want to just maybe come off mute and share, are you or how are you determining the success of your induction program? Are you measuring staff turnover, retention, tenure? Are we able to correlate that at all to induction training? Maybe, maybe not. Get ready, educators, L&D teams. I'm going to ask you in a minute how you're measuring. But just, a little seed to plant, as I said, that it's super important that we evaluate everything that we do. Think of the word evaluate. What's it got in it? Value. We can't demonstrate our value as educators, as clinicians, if we're not able to demonstrate the impact that we're having. So really critical to think of that. And for L&D teams, tracking knowledge, completion, and retention, or verification of competency following induction training might be some ideas that you could use to evaluate your induction training plans. So really quickly, this is a couple of slides to go. Anyone want to share some really creative things that are low cost, high engagement? Come off mute. What are you doing in your organizations? Super brief because we're at time. Does anyone want to share a quick tip or a change that you've made recently that you're getting great success with, or just want to share something you've done? Ganda, go for it. Would love to hear from you.
Sorry, it's Garda.
Sorry, Garda.
That's okay. That's all right. So I'm the workforce liaison officer at Meditech for my staff. And we have quite a fair few of them. I was one of the lucky ones where I had to do 32 modules. So that was good fun for me because I come from support worker backgrounds and now I've moved into a role in the office for the last 2 years. So I find that because I'm kind of a supportive role for our field staff, I've given them the whole, if you need any support, if you need any help with any of the modules, feel free to call me. And I'm more than happy to assist you in that regard. If there's anything that you're not understanding, then, I can help you with that. I try and arrange a meeting for them to come into the office and I can sit down with them one-on-one. And I find that when they have someone that they can go to directly, they're more compliant with wanting to do the modules, because I think there's about is there about 20 or 18 of the support worker modules in total. I didn't know about the RPL, which is really good to know because now I can kind of encourage them more that way to complete the modules. It took me about a week to do all of them in between my admin work, but I just find if they have someone that they can kind of go to, they're more inclined to do the actual training, especially because they've already done it through Meditech already. And a lot of it is very, very similar to what the AusMed ones are very similar to the AusMed ones. So I feel like if they have someone to talk to, then they can kind of, they're more encouraged to do it.
Right. Absolutely. Look, that's human nature, right? We want to build that connection. We want to have that support, someone to walk us through change in a new situation. So thanks for sharing. We brainstormed some ideas in our team. Personalized welcome pack, like literally a handwritten note to someone. I've got posties on my desks everywhere. Lunch with a manager. Everyone has to eat. Everyone have to take a break. You don't even need to pay for it, but just even organising time for someone to have lunch might mean a hell of a lot to your new starter. Within your orientation program, what about a 10-minute Q&A where you get other staff on the floor to answer any new questions from your new starters? A peer-led Q&A. Having a social buddy, which I think, a similar concept, but we tend to have, most organisations within the supernumerary time will allocate a buddy, maybe a preceptor in a more formal situation. But what about a social buddy? What about someone to answer those questions or just support you to help get to know people? Small wins. Doesn't cost any money to say thank you, well done, congratulations, showing those little shout outs for either your new starters or colleagues that are doing the hard work and facilitating and onboarding staff. Let's celebrate those small wins. And I thought this was a cool one. Someone mentioned open door time. I know when I was in intensive care, our manager would always have her door open, and that may not be realistic all the time, but just having that visual that someone is approachable may be the difference between that new starter feeling really comfortable in your area to a little challenge. So we'll send this out. Here's a little checklist just to keep in mind some of the fundamental principles that we've gone through today to help streamline things. with the two key things being, I think, staggering or spreading out your training plans and ideally leveraging some sort of recognition of prior learning. There is so much more to cover in induction program. I haven't touched on visitors or volunteers. Volunteers do need induction training. There is a lot of frequently asked questions. Should it be the same as mandatory training? When should I, what should my open rate periods be and things like that? So that's coming soon. I am close to publishing that one. So make sure that you keep an eye out for it. We'll try and answer those questions and more. If you subscribe to our toolbox, if you haven't already, you'll get access to this guide directly. Scan the QR code or visit the website there. I promise you it's one email a week. I send it. I'm not you, but encourage you to sign up. And I really thank you for attending today. We have tried to unpack some helpful strategies to streamline induction. It's a challenging area. Next webinar, we're going to do the same, but we're going to be looking at mandatory training, another area ripe for reviewing best practices and maybe mixing things up, having a few things clarified. So this is the first of a 4-part series. If you haven't registered for the others, click there. And just a little call out for anyone that is in aged care or home care. We've got a lot of webinars on at the moment, but this is just a little refresher for some of the key changes that lay ahead of us and are fast approaching in terms of the strength and standards. Just a little touch base to help everyone stay on track and ahead of schedule. So register for that one or stay tuned if you haven't. So thank you all very much. I appreciate your participation. I'm sorry we've gone a little bit over. Pop your hands up or stay on the line if you have any comments, questions, any feedback. Otherwise, I hope to see you all next time.